Hey, Mike Gibson, Andrew Althouse, talking today about the win ratio. I got to say, Andrew, more and more of the trials that I run are using the win ratio. I've become a student of the win ratio. I'm a big fan of it, but I think we have a lot of work to do out there to educate some of our colleagues about it. You had a great tutorial on Twitter talking about the win ratio, and I thought it was so good that I thought maybe you and I could walk through it and have you explain it again in terms that all of us can understand, so that all of us can get on the same page about what it is, how you do it, what it means, what are some of its limitations. So I'm going to throw it over to you, Andrew, to kind of go through your talk.
Hey, thanks a lot, Mike. Thanks so much for inviting me. I agree. I think this is, now that we're seeing this more and more in clinical trials, I think it's really important to make this accessible to folks to understand, what it is and why we're using it. So I think the first layer of motivation for the win ratio in your typical randomized clinical trial that we do to test for the benefit of a treatment, we usually choose sort of one primary endpoint to test whether the treatment is better than whatever we're comparing it against. And now there's good reasons to try to focus on one primary endpoint, because when you test a lot of endpoints, if you don't correct for multiplicity, there's kind of this concern that you might get one positive finding by chance, even when there's no real effect of the treatment. So that's why we don't just let people say, well, we're going to test on death and MI and on stroke and on cholesterol and on blood pressure, because the more tests you do, the more the chance that you'll get one false positive. So we try to specify that you need to pick one primary endpoint. But of course, sometimes, more than one thing is necessary to capture, the benefits of a therapy, right? People don't just have those things in a vacuum. These are all things that matter to patients, particularly those with cardiovascular disease. So we often create sort of composite endpoints. And this is a term that people who read cardiovascular literature will probably be familiar with. Something like major adverse cardiac event, or often abbreviated as MACE, is often the endpoint in our cardiovascular outcomes trials. And this might be something like death, myocardial infarction, or stroke. And now traditional analyses of MACE and other similar composites usually just kind of take the time to the first one of those events. So whatever happens first, that's when the patient is considered to have met the endpoint. And there's good reasons for that, but the downside of that is it doesn't really differentiate the severity of those events. A patient who has an MI kind of counts the same as a patient that died. And as we know, these days, fortunately, a lot of patients survive heart attacks. So it's a little bit odd to have death and MI as an endpoint when death is a lot worse than an MI. It's also hard for composites like this to also simultaneously incorporate how a patient's doing. Like if you've got a measure maybe of their quality of life or their 6-minute walk distance, it's hard to put that into this analysis of MACE, right? That's kind of a different type of information, and it doesn't easily fit like in a time to event analysis, until that happened. And maybe we even want the primary analysis of our study to test that functional outcome, be it like a quality of life measure or some sort of measure of physical function or 6-minute walk distance. But somehow we also want to penalize those bad things that might happen along the way, like death or hospitalization. Because a lot of times, if you see a trial maybe that has a physical function or a quality of life outcome measure, and you look hard at the analysis, sometimes they'll just compare it in the people who are still alive. And ideally, we want to somehow penalize the people who are too sick to do the test or who died before doing the test. We want that counted as a bad outcome, because if you think about it, comparing those outcomes only in the people who are alive could actually make an effective treatment look like it's not very good, because it happens that it's kept all the sickest people alive and they've survived to do the test.
Exactly.
So that's why
that's a tough one. That's a tough one to explain to people. I find that when I'm going through this and looking at the number of people who are left, there's quirky things that can happen. Those survivors can be a little higher risk, than the other group, and quirky things happen. The other thing I'm glad to see here is mention that you can pop in a continuous variable.
Yes.
An ordinal variable that's a continuous that gives you a lot more statistical power. Usually we don't lump together yes, no categorical variables with continuous variables. I mean, this is one of the beauties that I love about this method.
Yeah, completely agree. That's one of the things that I found when I sort of first started looking into it that I found fascinating. This ability to put multiple different types of endpoints, different types of outcome data into a single analysis in this very elegant way. So since you mentioned that, let's walk through a relatively simple example, maybe for people who haven't encountered this, just to think about how this works. What you do is for every pair of patients, every treatment and control patient in your data set, you go down your list of endpoints and you pick a winner in a way that you have sort of pre-specified in this order of endpoints. So for example, suppose the very first layer of my endpoint is death. I will treat a patient that is alive as a better outcome than a patient who died during the study. So if I have a pair of patients, one treatment patient who is alive and a control group patient who passed away during the study, the winner in that pair would be the treatment group. So that's very easy. Hopefully everyone can understand that. Now suppose I've got a pair of patients, a treatment and a control patient, that are both alive at the end of the study. So right now they're considered neutral on that level of the endpoint. So what happens there?
Or a tie. We call that a kind of a tie, right?
Right. They're right now they're a tie. At step one, this pair of patients is a tie. Correct. So now we take it down to maybe my second layer of the endpoint will be hospitalization, if a patient was hospitalized during the study. So if I have a treatment patient who was alive and was never hospitalized, and a control group patient who was still alive at the end of the study but was hospitalized, again, I would consider the treatment group the winner here because the treatment patient was never hospitalized during the study, and we consider that a better outcome than the control group patient being hospitalized.
And can I ask a question?
Please.
If both people died, the loser is the person who died first? Is that right?
Correct. Yeah. So I've for my little picture on this slide, I actually kept it as simple as just alive, dead, hospitalized, not hospitalized. But you are correct. And again, this is one of the incredible things about the win ratio approach. You can get even more granular, like you just described. You can have it such that if both patients died, the one that died first is considered the loser, or the one that survived longer is considered better. Same with hospitalization. If I have both of these patients are still alive at the end of the study, and both patients were hospitalized at some point, I can say the one that was hospitalized sooner is a worse outcome than one that was hospitalized later.
So you can integrate a time to event analysis into this to really get granular on this.
Absolutely. That's, again, one of the amazing things. It can put together time to event outcomes and binary outcomes and continuous outcomes. All different types of outcomes can be put together into that one single analysis. So that is really, really a neat thing about the win ratio approach. Hospitalization, what other comments to make on that? You could also do it if you want to account for the number of times they were hospitalized. So you could say that, all things being equal, a person hospitalized 3 times is worse than being hospitalized once during the study. You could do it by the number of times hospitalized in a particular amount of follow-up time.
Or the total duration of all the hospitalizations.
Days.
That's something, I've met with the FDA. They really like this number of days alive and out of the hospital. Well, the opposite of that is dead, and the total number of days in the hospital.
Yeah, and that makes sense, because I think that's a really patient-centered sort of outcome. You can say days alive and out of hospital. I really like that endpoint because of the patient-centeredness of it. Completely agree. So now let's suppose we've got 2 patients that are both alive. They're both not hospitalized, so they're still tied after the first 2 levels of our endpoint. And now we're going to do a 6-minute walk distance for these people after a certain amount of time. Maybe they've been treated for 6 months. For the people who are still alive and out of the hospital, we get a 6-minute walk. And in this case, if the treatment patient has a higher 6-minute walk distance than the control patient, we say that they're doing better. They have better physical function. So we consider the treatment patient the winner there. So
this is one of the things I love the most about this whole thing, because, look, not a lot of people are going to die. Maybe not that many are going to be hospitalized. Maybe you're going to have at most, I don't know, maybe 8 to 10% event rate in, say, an ACS trial. But then if you don't have an endpoint, say you're the 90% of people who don't have an endpoint, you still compete. You still compete on this continuous variable, and it gives you tremendous statistical power.
You still compete. And again, to come back to the patient-centeredness, I feel like one of the things that I've been trying to be very mindful of, in whether it be heart failure or ACS, we don't treat people just to keep them alive, right? Hopefully we treat them with the intent that they will feel well, that they will have good quality of life, that they will regain their physical function.
Well, as I always say, we aren't just adding years to life, we're trying to add life to years. So it
Yeah.
integrates both those. Yeah.
Yeah, I love that way of putting it. Yeah, we want these people, we want everyone, not just to survive, but to survive and hopefully, thrive and do well. So I think this is a way to try to make, I really think of it as a way to try to make outcome analyses even more patient-centered. People care not just about whether they'll survive, but whether they will regain their physical function or have good quality of life. And this is a way to kind of wrap all of that into a single statistical test for the therapy. So it's a very powerful way of testing sort of a therapy's effect on this holistic, death, hospitalization, and physical function sort of all wrapped up together. So one of the things we've alluded to a few times as we've been talking is that with this approach, you can almost say the possibilities are endless. Any endpoints that you can come up with, you can put them in an order and come up with a way to declare a winner. And, you can, like we've said, you could say death will be your first endpoint. If both died, you can kind of rank them by the amount of time they were alive. If they're both still alive, you can go down to a tiebreaker of number of times they were hospitalized or amount of time. You can go down to a quality of life or a functional endpoint. So it really has this wide, breadth of possibilities. And it allows you to do one single analysis and statistical test for those multiple endpoints and bring you into this answer of, did the treatment patients overall do better than the control patients? So that's really, really neat. We've talked a little bit about, the truncation to death problem if we have like functional endpoints in trials. This doesn't make us do an awkward thing like fill in a value for a 6-minute walk for a patient that died. Assigning a value for that patient just has always felt very awkward to me. Mm-hmm. But let's talk about some of the things that are tricky about it. As well. So I will admit that sometimes explaining what this is has proved a little bit tricky. What the win ratio is in the end, like we said, you take every pair of treatment patients and every pair of treatment and control patients paired against one another and declare a winner in the way we were looking at a few slides ago. And then so the win ratio that we actually calculate at the end, you divide the number of wins for the treatment group by the number of wins for the control group. So a win ratio of 1 means that the treatment and the control group had exactly the same number of wins. A win ratio above 1 means that the treatment group had more wins. Obviously, so a win ratio of 2 would mean that there were twice as many wins for the treatment group as the control group. Or in my little example here, 1.75. Okay, so there's 1.75 times the number of wins for the treatment group and the control group.
And,
so that's
let's talk about the number of comparisons here. I mean, just a small study, like 300 people in this arm, 300 people in that arm. You're doing 90,000 competitions.
Yeah,
300. Right. This one guy, patient number 1, is competing against all 300 of those people. Mm-hmm. Patient number 2 competing against all 300. So you're talking about 90,000 competitions for that one endpoint. So this is giving you a lot of numbers, right?
Yes. And I think that's an important point because I actually was explaining the win ratio to someone recently, and they asked if I could say how many people sort of had contributed to each part of the endpoint. And I said, it's actually more complicated than people. It's actually like the number of pairs. Like you said, it's all 300 people in this arm compared against all 300 people in that arm. So it's not like I just say that there were, 20 treatment group patients that won. It's like, you've got to talk about the number of pairs that are contrasted. So what this turns into, in my opinion, is that this is really, really effective sort of as an overall test of whether the treatment group patients do better than the control group patients. But it actually can feel a little bit hard to explain the size of the treatment effects to people. What exactly does a win ratio of 1.75 mean? I think people generally grasp the idea of a relative risk, that it means that you're a certain time percentage, more likely to have a bad outcome or something like that. This, even though 1 is still kind of a neutral effect and above 1 and below 1 can still kind of be explained, the actual number itself, I think, has proven a little bit tricky. The other thing is that a lot of times, even after we do this, people still say they want to know the effects that the treatment has sort of on the individual components. They want to know whether the result was driven primarily by death or hospitalization or by sort of the lower priority endpoint. Now, I've heard the concern expressed that if we start doing these for pivotal trials, and sometimes the results are maybe driven by what I'm calling the lower priority endpoints in the composite, the things that are kind of at that third and fourth stage, some people are concerned about whether we'll ever get really good, strong RCT data on sort of the higher priority endpoints like mortality or hospitalization. So I just do want to acknowledge that I've heard this concern from folks that they feel like they even if they get the statistical argument for the efficiency and the way to fold a lot of things into a single analysis, I think the people that are never convinced unless they see a mortality benefit are going to have a hard time maybe
But I got to be honest, Andrew,
accepting this.
someone who does lots of mega trials, I mean, these are billion-dollar studies,
Yeah.
to even do a regular composite endpoint. I mean, imagine if we could do something that has much more statistical power and cut that down dramatically. We
Yeah.
could have some more shots on goal in terms of all of the potential treatments that are out there. We've got to be more efficient. I mean, I think this is doing what you said. It really tests the null hypothesis. Are these two treatments, is there any difference between them that is not explained by chance? It tests that question, but to look at the clinical magnitude, okay, we can break it out with some traditional descriptive statistics with some confidence intervals around it could be up to this or that much to satisfy the naysayers. But I think if the overall thing works and if everything's lining up consistently in the direction of favoring the treatment, if it all fits together well, I think it's a pretty compelling argument.
Yeah, I agree. And like I said, I think the thing I'd love to emphasize is that I love that I think it gives you a way to fold more patient-centered outcomes like their physical function and quality of life into those analyses. And like you said, if we can get an answer, because our goal isn't just to increase survival, it is also to increase quality of life and like you said, add life to years, not just years to life. And I think that the ability to run, as you alluded, sort of more efficient trials and maybe get effective therapeutics out there with trials that maybe only need 400 or 500 patients instead of 5,000 patients. Like you said, a lot more shots on goal, a lot more opportunity to get these things done sort of more quickly and in a more expeditious fashion and get those therapies to patients. So I agree. The benefits are certainly worth considering, I think.
And the quality of life stuff is important. People want to be alive. They want to be out of the hospital and they want to feel good. I think we can do so much more of this now with virtual trials. I mean, that's what I'm running with the Apple Heartline study, where we're using apps to enroll. We're using apps to collect all that. How are you feeling? We're using claims databases to see, are you dead or alive, or did you have something bad happen? And we're able to do it at 1% of the cost of a traditional trial. If you couple that with more efficient statistical methods like this, I think we could make a lot of headway in really streamlining trials, getting answers quickly, and having more potentially, effective treatments out there for patients.
Yeah, I
That's
mean, the randomized trial was such a huge leap forward in our ability to test whether treatments are beneficial. The next big leap forward that we'll get is that increased efficiency that you're talking about, being able to do them, cheaper, faster, and with less burden to the participants and to the treating clinicians.
Yep, I agree. Did you have anything else, Andrew?
No, I think that's about it. Thanks so much for taking a few minutes to talk to me. Hopefully this is helpful for people who have not encountered this before. Hopefully it's a little nice explainer. And
it is.
Yeah,
and your tutorial was great. And I got to say, most of the trials I'm doing now are relying on this. So we have a lot of work, I, and other trialists, on educating people. Thanks so much for joining us today. And we're going to get this out there so everyone can start to digest all this.
All right. Thanks a lot.
Thanks, Andrew.